Hi, my name is Mary Reed, and I have Janelle Myers with me today. We're both OTs working for Mary Freebed at Covenant. We cover NICU, PEDS, and OB. And today we're going to be talking about basic assessment and treatment of the newborn to 1-year-old. So a few objectives for today. We're going to identify typical developmental patterns up to a year. We're going to identify atypical developmental patterns and indications for referral to early intervention services. We'll learn about assessment tools and we'll generally increase the knowledge of treatment approaches. We have divided this up into 5 groupings that correlate with large milestone achievements.
So we're going to look real quickly at prenatal and birth history. When you have the opportunity to gather this information, it can be helpful, especially when evaluating and treating the very young patients. So even newborns have a history. If you can find out anything about prenatal care or prenatal events, mother's history, if there was hypertension, surgical history during pregnancy, blood sugar issues, drug abuse, things of that nature. Birth events, was it a healthy full-term delivery, any complications, type of delivery, C-section or vaginal. Percentiles of height, weight, and length are helpful to know if the baby is growing appropriately and meeting those milestones. And then APGARs are a helpful tool that stands for viability of the newborn infant. It's a 0 to 10 scale, 8, 9, and 10 being your ideal scores, 0s, 1, 2, 3, 4 being less healthy newborn infants that may cause neurological complications later on. So the newborn, when you're looking first for assessment, you want to look for basic reflexes. So things like hand grasping, toe grasping, rooting, sucking, all those should be present and equal and symmetrical. You want to assess for quantity and quality of movements. Is the baby floppy, low tone, tight, rigid? Do they jerk a lot or tremor? What is the quality of the way that they're moving? You also want to look at their states, which is a classifying system of, are they awake, alert, sleepy, crying, fussing? And you should see that most typically developing newborns have a smooth and predictable state transition. So they don't abruptly go from crying to passed out asleep. You want them to slowly kind of wake up and fuss. They should also be easily calmed and comforted. And they should start to wake for feedings, but mostly be asleep for their 24-hour period. For feeding problems, feeding itself is a very difficult thing to assess and treat. But if they're having issues with feedings, that can be a sign that other things are not developing appropriately. Most importantly, safety. Do they cough, choke, or gag with feedings? And there's a real nice saying in the therapy world for pediatrics is once per day, we're okay with coughing, choking, or gagging, but once per feeding, we need a meeting. So once per feeding is not okay. There's definitely a sign of compromise, but once per day is typical just for children to figure out the safety and mechanisms of feeding and swallowing. We're not going to get into the whole topic of feeding and assessment and treatment. It's very complex, but it's a very good thing to ask parents about and to know if they're eating okay. That's a good sign of coordination, health, and stability. And then also, are they growing well? So we're going to look at a newborn case study, and we're hoping that we can use these case studies to guide you through the thought process of what you might see and what you might want to look at.
Okay, so this one is a 6-week-old, was born at 36 weeks and is now 2 weeks corrected. So we're taking that number from a 40-week is full term. So they are referred to you for a developmental screen. So the baby is eating well, but does not stay awake while when feeding. It was a vaginal delivery with APGARs of 8 and 8, which are both good. and then went home within 2 days of delivery and is only bottle feeding. So the reflex assessment was completed and the reflexes are present, but they seem weak. So pulling on the arms or pulling to sit, the baby's a little bit floppy. He moves all extremities, but doesn't move against gravity very much. He cannot lift his head off the surface in prone, but he moves arms and legs and head equally. He's alert for short periods, but very minimally active. You watch the feeding, and there's no coughing, choking, gagging, or spilling.
And spillage is just when the fluid comes out at the front of the mouth or the lips. A little bit is okay, a lot is a concern.
Okay, so some assessment findings. You find that the baby is low tone and has generalized weakness. So treatment would be educating parents on tummy time. The American Academy of Pediatrics recommends 90 minutes of tummy time per day by the time you're 3 to 4 months old. But right now, even as a newborn, it's perfectly acceptable to do tummy time as much as possible. And the baby should be able to lift their head and at least turn it side to side on his stomach. And then as far as feeding goes, with the baby not being able to stay awake, you can actually use firm swaddling to help maintain their alertness and give them some postural support and facilitation, which actually moves their energy. So it saves energy by you're doing the work for the baby, and then they can focus more on staying awake and the eating. And then you could feed them upright and on their butts to give them more proprioception and weight bearing. And then talking about play positions and sideline. And when you lay on your side, you use gravity to help the baby achieve midline and play that way.
So at 3 months, you're still may consider looking at reflexes, but don't be confused here because these reflexes should start to integrate. Not all of them will be present or integrated though at this age. So just kind of take them with a grain of salt. You wouldn't want to always walk around and if somebody tickles your cheek, you have that rooting response. So that's very appropriate that some of these go away. Looking at the 3-month-old for gross motor function, you should see that they lift their head for the most part with pull to sit. They start to move against gravity and they have reciprocal kicking of their hands and their arms and their legs. They bring their hands to the midline and mouth. So they're able to really draw their bodies up against the support surface against gravity. Prone, they're lifting their head up to 45 degrees and hopefully working on getting up to 90 degrees. Should start to rotate their head and then pushing their trunk against the surface for stability and bearing weight through their forearms. We want to make sure that they're pushing their hands down into the surface, which also helps to open their hands for fine motor activity later. And like Mary said earlier, tummy time should be well established at this point with 90 minutes per day. So here's an example on the left in the green onesie is the baby who has low muscle tone. And we just had these good examples of a baby that looks like she has a hard time bringing her body up against gravity. Her arms are kind of in a W position, flat against the surface, and her hips are a bit too. The 1-month-old with the cute little hairband is able to draw her hips, knees, and feet off the surface, and hands are kind of coming off as well. Head is in midline also compared to the baby on the left. You would have this
So one point about the brachycephalic, the flat in the back, those tend to be full-term babies that more often than premature babies, and can also be influenced by containers. We call it container baby syndrome is the term that's out there about even car seats and swings and bouncy seats all put pressure along the back of the head, pushing up the crown. And so you think you're circuit training your baby, but it's not getting enough off the back of their head. And it can lead to things like facial asymmetry too. So for example, I might use my pointer here. Around this part of the face with plagiocephaly, you can get bossing of the forehead as the pressure pushes in the back. It pushes this front forehead forward, causing issues with the eyes, the ear symmetry, the cheekbones, the jaw. So it's not just cosmetic, it can be very functional. So it's really important to look at head shape and educate early on head shape. The plates in the brain don't fuse for a few months, but this is really the peak window of opportunity. So our 3-month-old case study is a boy who was born at 39 weeks, so essentially term. He was referred to therapy for developmental screen from the pediatrician for concerns of fussing, inconsolability, and stiffness reported by his parents. They report that he likes to stand and not sit. They state that he rolled very early from his belly to his back, but now they don't notice it. It really only happened maybe once or twice. His legs are straight and shoulders are retracted, or the scapulas are adducted and arms are out to his side. On his tummy, he either cannot lift his head off the mat or he has a Superman positioning with no weight bearing on his arms or tucking of his hips. So there's our little baby Superman. He has strong right head turning preference, tightness in his neck, and a correlating flat spot on the back right side of his head. So feeding was observed. Again, no coughing, choking, or spillage. He does have increased fussing near the end of his feeding and has a small spit up afterwards. He's observed for frequent swallowing after his feeding. So what are we thinking with our assessment? Oops, sorry about that.
And it's helpful maybe to know as a therapist who wants to help these babies that are very uncomfortable and likely not sleeping and their families, they're really, the AAP has not found any great treatment. A lot of reflux is a wait and grow approach. Tummy time, though it seems like it puts a lot of pressure on the stomach, helps decrease reflux because you're improving the smooth muscle in your organs, so your esophageal sphincter and the shape of the rib cage to help keep reflux at bay. But again, there's no medications. They've even found that elevated sleeping positions don't help, or thickening feedings at all. So unfortunately, it's just a tough challenge.
And then you could also do supported sitting for weight bearing and extensions. Break up the extension patterns by flexing the hip.
Also working on to help with a flexion pattern, sucking is part of a flexion synergy. So if you can get that baby's hips flexed and then you get them to start sucking on a pacifier, and the sucking helps with the peristalsis down the esophagus, so that can really help with reflux management. There is a benefit to upright positioning with feeding and then holding the baby upright after feedings. Then when looking at the right plagiocephaly and potential for torticollis, that can lead to some tightness in the neck. So we talk to parents about environmental changes. So put all of their interesting items and the exciting things in the room to the side you want them to turn, which is usually the left with babies with reflux. And then we start with stretching exercises for the neck with ear to shoulder and chin to shoulder techniques.
Okay, so for 6 months, your gross motor you would have instead of sitting like a baby on the left, and hold the and keep your and it's going to again be well established. We would see in the baby with feeding. You would
So at 6 months, we actually get a referral for an 8-month-old girl who was born early at 32 weeks. Therefore, we want to correct her age. So 40 weeks is full term. You would take away 8 weeks from their age. So it's corrected age and chronological age. So she's chronologically 8 months old, but she's corrected at 8 weeks earlier, which is 6 months. Therefore, corrected at 6 months, sorry. She was referred to therapy because there were concerns with unmet milestones. The parents report that she likes time in her exerciser. And she is rolling.
She is resistive when placed in sitting, and parents are primarily concerned with this. So by resistive, they mean she tries to stand, she really fights or arches and pushes back. She does 30 minutes of tummy time per day and holds head up to 90 degrees with weight on her forearms. And we didn't mention this earlier, but we talked about the 90 minutes of tummy time per day, and definitely that can be broken up into segments. That would be 5 minutes here, 20 minutes there, and it feels like a lot throughout the day because it's broken up, but it does not have to be a solid 90 minutes straight in a row. There were no concerns with feeding. She breastfeeds well, and other foods have not been introduced yet. She has limited reaching for toys with W positioning of her arms.
What happens is they're often not fitted well for that. Usually, one of those items maybe 7 months plus. And granted, she is technically 8 months, but we as therapists prefer at 6 months. So she should not be in those. So when they don't fit, the baby is eating her, and that makes the calf muscle getting that. And then we find that's she has shoulder girdle tightness, and then I explained so decreased rigidity and finding ways to so when you're with this baby, especially because she has that W position and then this one, so back to the picture, it's often a dead way to do it is to start over normal because it takes away the difficulty of
It also helps with posterior weight shift. So shifting the weight to the back, to her legs, so she can get more effective weight bearing and proprioceptive input to her legs so that can decrease that tight rigidity. Think of your neurodevelopmental principles of inhibition and facilitation techniques. So when they're tight and they have higher muscle tone, the weight bearing and the deep pressure will help to calm and regulate that muscle tone. Play positions and sideline for midline that are gravity assisted activity and supported sitting for weight bearing and inhibition of extension. So in sideline, the nice thing is with a tight, especially the tight shoulder girdles, you have weight bearing on your dependent side, your bottom side, and then gravity is bringing the top side down towards midline and getting benefits from both angles in sideline play. But then also in supported sitting, you're getting weight bearing and then the flexion of the hips. The hips is one of your biggest keys for hyperextension and rigidity. If you can get the hips into flexion, you're going to break up that extension synergy very effectively.
And I think you notice the theme here that a lot of the first 6 months that you find for the most part, sometimes sideline and sitting are your go-tos. So even as a new grad, take these things at the time and they can affect so many things and keep them on. So then we would definitely educate the parents on the
and that they're only used for kids who are already sitting, and not, they should be fitted to the baby. So say if you have a small baby who's already sitting and they're too short for the saucer, textbooks or something, so that they can stand flat-footed in the saucer. And then you can encourage more supported sitting on mom and dad's lap or carrying the baby facing outward and keeping their hips flexed up. And then because of that toe pointing, you'll want to do some so just bringing the toes to the nose, and you'll want to do that several times with each diaper change.
All right, at 9 months, moving on, we've got gross motor for the more mobile child. So they should be independent with sitting and starting to have rotational movements, excuse us. Rotational movements of the head and trunk and protective responses to the side and the back. So when they're sitting, they're turning and reaching for toys, they can put their hand back while they reach across their body to grab a toy. They're starting transitional movements between positions, for example, crawling to sitting and back and forth. In prone, they should be able to get onto their hands and knees and do some rocking. They may start to propel forward. Sometimes backwards crawling comes first. They end up pushing with their arms instead of pulling forward. They also may pivot on their tummy. Some children can be very mobile by pivoting circular on their tummy or rolling to items that they want. It's good to have motivation to get moving. They may be pulling to knees and pull to stand, maybe at 9 months starting to cruise along the furniture. And that means just holding on while taking steps along the furniture. So with the assessment of this girl, we're finding that she does not protect herself with balance to the side or to the back when she's sitting and just topples right over without regard for safety. She cannot twist her trunk in sitting, therefore she's very limited getting objects and then she just falls. She also has very poor coordination and accuracy, so fine motor is a concern. And that when she moves her arms, they're kind of slow and heavy looking movements. She still uses like a raking grasp and not developing a pincer grasp at all.
So for treatment, we worked with father on prop sitting and side sitting, the goal being weight bearing inputs to strengthen and improve coordination. We love weight bearing. So prop sitting, where you can literally hand over hand place that child's infant flat on the surface and then give them a toy or help them reach somewhere where they're putting extra weight through that arm. Side sitting is really good because you use lots of trunk muscles and you have very heavy weight bearing on your arm for strengthening and coordination. Oh, and there's kind of a mixture of prop and side sitting. If the baby's right knee was put behind them and the left knee a little, or the left leg flexed a little bit more, that would be perfect side sitting posture. But that's almost like a transitional movement. Using a therapy ball with supported sitting position and then rolling the ball gently to challenge their weight shifting and encourage those protective responses. So you're imposing that movement on them to give them some practice. And hand over hand support to reach and do hand to mouth coordination to show them what they can do. Encourage age appropriate toys for fine motor coordination and play. Sometimes they don't even have the small enough objects to grasp and manipulate, because I think a lot of times people are scared for choking hazards. So finding things that might have like a long string on it, a pull string or something, those are easy to grab without being a choke hazard. And even just the puffs, playing with the puffs as a safe, meltable, dissolvable food would be a good fine motor task. And we did put this in here because this may come up in your practice, that you might consider a neurology consult to be discussed with the pediatrician. We are not advocating that you scare the parents and maybe say a little too much, but just know that some of these behaviors at this age do not seem appropriate, and they kind of fall along a line of neurology issues. So just mentioning that to the pediatrician in your findings may be helpful. For fine motor at 12 months of age, you're looking at purposeful reaching and grabbing, bringing items to their mouth. Pretty much everything comes to their mouth for exploration. And you should see a variety of grasping patterns. So the pincer grasp should be more mature, and they may do still the raking at times and cylindrical grasp. They should be developing better accuracy, placing objects in a container and removing them, and very easy puzzle pieces, large things that are easy to grab and place. And then you should start seeing single finger pointing.
He's a picky eater, and he'll pick out one type of food on his tray. Mom states that she has trouble and he startles when his parents try to assessment findings. He crawls with his feet up off the surface. He has texture sensitivity with clothing. He has vestibular insecurity, which is identified by walking along, even though he can walk and just one finger touching something.
And also his, that swinging for fun is like when you take a child, it sounds kind of crazy, but and you gently swing them up in the air or kind of tip them upside down, and they should laugh and giggle and smile, but he startles with it. He also has good strength. That's one thing that the mom would say is he's very, very strong, and I don't think it's his core strength. So we thought there was a concern for sensory processing disorder. And again, that's not really a label we're going to attach, but it helps us with an idea of where our treatment will come from. So a brushing protocol, for example, the Will Barger brushing protocol that includes joint compression would be recommended and instructed. Yeah, educate parents to support him with downward pressure through the hips when he's trying to walk. And this is to help with proprioceptive input and with stability. Another test that is available is a test of infant motor performance. This one you can do very early at 34 weeks gestational age, up to 4 months after their due date. It takes about 30 minutes to administer, and it is focused just on motor responses. A lot of head control, sitting, standing, and prone activities are accomplished in this. And it can be a nice gap for the very young children. Then the Bailey scales of infant development, some people call this the BINS. You can give this one up to 42 months, and it may take a little longer to administer depending on the age of the patient, but there's cognitive with expressive and receptive language, fine motor, gross motor activities in this kit. And you want to look at their quality of movements. They're not, you really want to look at those fine activities to say, okay, they're missing this building block. So we know that the next one might be in trouble of not being accomplished, because we want to make sure they're progressing along that developmental trajectory. So it's very helpful to know your typical developmental milestones, because we really have found that this is the blueprint for a therapist's toolbox. You follow this for your assessment, and then it helps guide your treatment so well. So you just look at the age of the patient, and then what developmental skills are they performing at, and that will tell you exactly what you need to work on. So they're definitely nature's building blocks for life. And there's our references. Yeah. And then these are our email address contacts, and we will be available for questions after this recording. Thank you.